I think it's safe to say that the answer for most complex proximal humeral fractures in geriatric patients anyways is going to be reverse arthroplasty. We haven't talked specifically much about reverse so far in this meeting. We have talked extensively on proximal humeral fractures, so most of this talk is going to focus on reverse arthroplasties. And I don't have anything to disclose in particular in that topic. So this could reasonably be described as a complex problem. It's a 78-year-old female who's active and healthy with no prior shoulder pain. You can see that she has this pretty severe fracture dislocation with the humeral head buried down in the axilla. And I think most of us recognize that trying to fix this fracture in a patient this age would probably be a pretty futile thing. The humeral head there looks like it's got almost no soft tissue attachment whatsoever. You might be able to piece everything back together again, but the chance of that healing and being functional is pretty low. And so in my hands in 2025, this is a reverse arthroplasty. And you can see we've made a real effort to put the tuberosities back where they belong. I think if I see one common technical error with arthroplasty, reverse arthroplasty for fracture these days is no one puts the tuberosities or the tuberosity reconstruction is kind of felt to be unnecessary. It's absolutely true that in the reverse, the tuberosities are not as critical as in the older hemis we used to do, but you still get a better shoulder out of the deal, especially rotational strength and perhaps stability if you get the tuberosities back down. So if you are going to do these procedures for fracture, then make sure you spend some time doing the tuberosities. It's the hardest part at the end of the case, no question. You can mobilize them extensively. Personally, I just take the top supraspinatus and just cut it right out. It's a deforming force you don't need in reverse. So you've got subscap and the lesser in the front. You've got infra and the greater in the back, and you just bring them around the stem. If you don't have that pull over top, then it really makes the tuberosity management quite a bit easier, and you don't need that cuff up top like you absolutely have to have for hemiarthroplasty. So that's my kind of standard approach for these cases now. Is there anything to support my bias? Yeah, there are actually some pretty good randomized trials out there. Sorry that the title's cut off a bit there. But this is a randomized trial from Scandinavia looking at fixation versus reverse in a multi-center trial, and it pretty clearly showed that there's a statistically significant and clinically relevant improvement in patients who got reversed. And if you look at these subgroups, the more complex the fractures were, the more B and C type fractures in this, then the greater the difference was. So the older patients with more complex fractures, there's pretty good scientific evidence now the reverse is probably the treatment of choice for those individuals. How else can a reverse be helpful? Well, if you have pre-existing shoulder conditions, you take a bunch of 80-year-old people on average and you look at their constant shoulder score, it's not 100, it's probably around 65 or so, because many older patients have a significant pre-existing condition in the shoulder. Usually it's cuff, but it can be arthritis as well. This is a patient I treated a couple years ago. You can see she has severe pre-existing arthritis in her shoulder. When she fell and broke it, and she said, my shoulder's been stiff and painful for years, but I just never got around to doing anything about it. So if you fix this fracture, you're just going to give her a stiff, painful shoulder again. So this is obviously someone who would benefit from having an arthroplasty done as well as fixing the fracture. If you look at some of the characteristics of the glenoid here, it's probably going to be tough to do much except a reverse for this patient, which is what she got. And that's her outcome there. And she actually said that breaking her shoulder is the best thing that ever happened to her because her shoulder got better after this than what it was like before. It's pretty miserable. Obviously a complex case. You may not want to tackle that one yourself. One of the nice things about doing reverse in the trauma world is usually the glenoid is virginal. There's nothing there. It hasn't been operated on before. It hasn't got that big, terrible wear that the arthritic patients have. It's sitting right there looking at you, which is great. And so the glenosphere part of it's not too difficult a part of the procedure. It's the humeral side that you have to take care with, and this patient actually did pretty well that way. We don't see as many as we used to, but in the past, the failed hemiarthroplasty was a common theme. This case kind of encompasses two themes. This is a nurse actually who had this fracture dislocation. If you remember, we talked today about the iatrogenic fracture dislocation. If you look really carefully here, you can see that the humeral head's kind of pointing up, not in, because it's been squashed down, and there's really just a faint fraction line right there. So this is the danger case for trying to do a closed reduction, as we spoke about the other day. She had a closed reduction, and this is what happened. You can see the head's sheared right off now. The shaft's kind of back. So this is pretty much an instant arthroplasty. In the old days, would be a hemi. This is not my image, but I think if I got this intraoperatively, I'd be pretty happy. The humeral head looks concentric with the glenoid. Size looks about right, maybe a bit overstuffed, but not terrible. The tuberosities back down where it belongs, so everyone should be happy with this. Then the patient comes back, this is 6 weeks out, and this is disaster. So you can see that the tuberosities pulled off, the head subluxating out, and the best this patient can do is this kind of shoulder shrug in terms of motion. So now you have a huge problem on your hands. The hemiarthroplasties are extremely dependent upon tuberosity healing. If you don't get the tuberosities to heal, your hemiarthroplasty is terrible, and this is a major problem. So you have two options here. One is try and go back, put the tuberosity back where it belongs, maybe try and fix it with a little plate, put them in a splint forever, hope that it heals. That has not been routinely successful in my hands, or try and revise this freshly cemented stem. So that's a big issue for this patient. And we talked a bit about this before, but if you look at the two main papers in literature looking at this iatrogenic fracture dislocation, there's 14 total patients. All had poor results with fixation. All had poor results with hemiarthroplasty. So if you have this kind of problem where you displace the head, you probably are looking at a reverse arthroplasty for this patient. And that's what she has. You can imagine, we had to pretty much fillet the proximal humerus to get that stem out. What about looking at primarily reverse versus hemi? Well, there's a number of randomized trials out there that are pretty good. I think this one, which is a bit older now, probably is pretty much close to truth. RSA in general, the reverse was better than the hemi for constant scores. That's a pretty significant clinically relevant difference. Better flexion, better dash, and 6 of the patients in the hemi groups, that's about 6 out of 31, had to be converted to a reverse. If you do a hemi and the tuberosities heal and it goes well, that's a great shoulder. It's durable, it lasts forever. The problem is if the tuberosities don't heal, you get what we had in that last case, it's a disaster. And it's very hard to predict who that happens to and who it doesn't happen to. So I used to do hemis all the time for fracture, and most of them did very well, but I get this occasional disaster case, like 1 in 5 or 1 in 6, and really I did the same thing every time and just couldn't predict which ones the tuberosities would either pull off or they just kind of melt away and the patient had a major issue. So I think in general now for older patients, this is a geriatric seminar, remember, the reverse is better. If you do have a failed hemiarthroplasty, I think that's another good indication for a reverse these days. In my mind, this patient's 2 years out. She's never been happy with her shoulder. You can see the cement mantle is loose. This patient has C. acnes infection until proven otherwise. So if you look at the failed hemi, an alarmingly high number are due to either recognized or usually unrecognized underlying C. acnes infection. I'm going to do this in a one-stage exchange. In 1 versus 2 exchange is another whole topic, but in general now I try and do it in one stage. I'm going to assume it's going to grow C. acnes. I'm going to take everything out. I'm going to curette out the shaft, wash everything out, debride it completely, do my operation, and then pack in some powdered vancomycin at the end. So on day 3, some of my cultures come back, positive for C. acnes. I feel pretty good about what I've done inside the shoulder. And she's not perfect, but she's a whole lot better than she was before. One thing that's important, if you do want to use a hemiarthroplasty, which I think is still quite reasonable for a younger patient, like a 55 or 60-year-old with an irreconstructible fracture, I think it's perfectly reasonable to do a hemiarthroplasty in 2025, but try and use a platform stem. And by that I mean, if your hemi fails, if the tuberosities pull off or the cuff fails, and you have to revise that to a reverse, then having a platform stem makes things much easier for you and better for the patient. This is an example of a failed total shoulder arthroplasty. You can see the stem's been kept in place. The glenoid comes out fairly easily, a new glenosphere goes in, and then the same prosthesis in the shaft, so you don't have to discombobulate the entire humerus getting it out. There's pretty good evidence in literature that if it's possible to do that, that your stem intact group, that means the group that had a platform stem that wasn't revised, has much less blood loss, quicker OR time, fewer complications, and fewer revisions. Remember, though, it's not always possible, even if you have a platform stem, to keep it. Usually, if it's too high and it's just too stuffed, then you have to change it. So even if there is a platform stem, remember, it may not always be possible to keep that. The last things for failed open reduction internal fixation, I see a fair number of those still. This is obviously some of the AO principles were not followed here. For those of you in the audience who recognize an old an old rush pin trying to hold everything together here, which is obviously falling apart. This patient had a completely avascular humeral head. You can see there's the glenoid there. In these cases, the glenoid usually is pristine, and you take the head out. It's a great view. Usually my junior resident does the glenoid base plate in these cases because it's such a good view and a straight shot. And that's him afterwards. He had a pretty good result. Not normal, but much better than what he was left with before. There's some information out there. Remember, most of the most of the papers that talk about reverse as a salvage for failed open reduction come from academic centers that have a great deal of experience with this. They can usually get a pretty good result, and you get better, but there's still a high complication rate. It's hard to reproduce that on a general population level. So this may not be the first reverse you want to do. In your practice, you probably want to send this on and have someone else do it. But it is a pretty solid salvage operation for these patients, though it still has a high complication rate. What's the lowest, the youngest I've done a reverse for? Well, this is one, you know, we drift down to the 50s, you think, is this someone you should do a hemi and a reverse? The reverse is a more reliable operation, but the hemi is a more durable one if you can get away with it. If someone works overhead a lot and they're in their 50s, maybe you should think about a hemi and try and make that work with a platform stem. This person wasn't that active, actually had some comorbid conditions, so we just went straight to a reverse for this patient, even though they're only 56. That's completely different from what we would have done 10 or 15 years ago, where it's only for patients over 70. So just consider there is some variability in that. And I'll stop there. Thank you very much.